I'm looking forward to being 17 again. So, good morning, and thank you for everyone for coming and being part of this. This is, I think, a really unique opportunity and really a unique way of looking at healthcare improvements that Lori and her team have put together over these last years. And I'll briefly just tell you that I sort of came to public health and trying to improve prevention programs in sort of a kind of backwards way. I don't have an MPH, I don't have a PhD, I'm just a good old-fashioned MD who found myself taking care of lots and lots of sick children over many years and started to realize that there was something wrong with a system where so many children had diseases that could be prevented. And this is a problem in our country as well as many others. And so I tried to look for what would be the most impactful component of prevention around infectious diseases that I could get involved with and really find a place to be and a space to try to really make real improvements in the quality of what we do. And immunizations really spoke to me from an early age. I had many of the diseases that are prevented by vaccines now. I had mumps when I was a child and chicken pox. I had typhoid fever some years ago, and had one of my many near-death experiences, which I'm particularly good at. So everybody is particularly happy when I make it to each birthday because it's not clear that I'm going to make it to the next one. And have seen many, many people suffer from these diseases unnecessarily. And one of the things that I'm really concerned about in our country is that people have lost really the value of vaccines because as these diseases go away, people start to forget about how bad they are. And so what I want to talk to you today about is a little bit about why immunizations are so important, and then talk to you about one of the many projects we've been involved in working with the Ministry of Health in Kenya, and then a program that we piloted that then has been now rolled into 8 different sub-Saharan African countries. And then a little bit about what we're anticipating and trying to prevent with this whole idea of vaccine hesitancy, because we have more and more families, especially here in the United States, who are starting to question the value of vaccines and really trying to struggle to continue to share the message of why these are so important. So as I mentioned, vaccinations are by far the number one most important public health achievement, certainly in the United States, if not the world, ever. And I say that with some grandiosity, but with data to support that. That in 1999, at the end of the last millennium, everybody was expecting that when the millennium hit, all the computers were apparently going to melt and all the airplanes were going to fall out of the sky and doom and gloom was all going to fall upon us. And I have this vision of the Center for Disease Control hunkered down in their bunker, adding up all their successes over the previous 100 years. And so they actually published this paper in the Mortality and Morbidity Weekly Report where they basically kind of tallied up all of the health achievements in the United States over the previous 100 years. And no matter how you slice it, immunizations prevented more death and more morbidity than any other public health intervention that we had ever made. And yet if you walk up to most average Americans and ask them what the most important public health achievement is, that probably wouldn't even come into their top 10. And that's how far we've come in a program where we've been able to essentially almost eliminate many of these diseases. When we think about where our goals are and what we're trying to achieve, initially in most areas where we have abundant resources, we've been able to introduce vaccines that actually are designed to prevent morbidity with diseases that don't necessarily kill a lot of people. And so diseases like rotavirus and hepatitis A and varicella are all diseases that most people survive, but they do cause substantial morbidity. They cause lost time from school and work for the families, and they often cause small outbreaks in the communities that really do cost society a substantial amount of money. Currently, and I think it's sad to say, currently in less resourced areas, we're still focused on trying to introduce vaccines that prevent mortality. We have yet to really be able to mobilize the resources yet to be able to introduce most of the vaccines that we look at as being really important in our programs that I think everybody worldwide deserves to have. And I think that one of the initiatives we've been working on when we try to improve immunization programs is to show that we can reliably administer the basic vaccines that prevent mortality so that then we get more attention and more resources to then start adding in subsequent vaccines that will also be able to prevent morbidity. our goal for all the world is the same, is that we want to eliminate these diseases and eradicate these diseases and eventually get to the point where we can actually stop immunizing. So we have 2 diseases that we've eliminated from the face of the earth. Does anybody know what those are? So smallpox, we eliminated from the face of the earth by immunizing. And what's the other one? So rinderpest. And rinderpest is measles for animals. And it used to kill enormous herds. Much of the famine that many of us saw in the 50s and 60s and 70s was because of rinderpest. And I think it's very interesting when we think about immunizations and healthcare programs that we are so human-centric, that we are so focused on human health that we forget that, in fact, there are so many other components that contribute to human health. And we know about environmental concerns and water and food security. But I think we really need to recognize that the health of animals is actually a direct contributor to the health of humans, and that immunizations are one of those things that actually crosses that boundary. It crosses from immunizing and protecting humans, enabling us to actually protect animals. And in fact, there are probably, I added this up one day on a website, there are probably about 100 times more vaccines for animals than there are for humans. We can immunize about 30 diseases in humans. There are literally hundreds and hundreds of vaccines that have been developed for animals. And that's a whole other component that once I solve all of the human health problems with immunizations, I hope to still be alive enough to eventually be able to start to be an advocate for animal immunizations someday as well. Now, how do we try to achieve this elimination of disease? You know, we know that we could never immunize every child with smallpox vaccine as quickly as we needed to. People make babies far faster than we can get needles into those babies. But what we depend on is what we call herd immunity. And herd immunity is essentially making sure that we've immunized enough of the population so that even if an outbreak occurs or a case is introduced into the community, that there's enough immunity amongst the herd of the people that the disease doesn't spread very far. And that's how we eliminated both smallpox and rinderpest, is that we immunized enough people that even if there were small cases, there weren't enough people susceptible in those communities that they could actually get sick. So this is how this works in a quick cartoon. So in this cartoon, the blue people are the innocent, unimmunized people. The yellow people have been immunized, and the red people have some kind of disease. And they get off a plane, and they step into this community, and you can see that it's very easy for one of these people with a disease to come into contact with somebody who's unimmunized, and for the disease to spread very quickly. Now, this is what we are trying to achieve. We're trying to achieve enough of a population that are vaccinated, that are in the yellow, so that if one of these people in red walks into the community, yeah, there's a small possibility they may come into contact with one of these individuals who is still susceptible, but they probably won't come into contact with very many. And so that disease may spread to 1 or 2 people, but doesn't spread very far. And so this is the critical component of the public health of immunizations, is trying to achieve enough of a population that are immune that diseases can't spread. We know that there will be people that are not completely protected. We know there are some people that may have an allergy to the vaccine, or somebody that may have an immune deficiency and may not be able to be vaccinated or may not respond to the vaccine. But we also have to acknowledge there are some people that just choose not to be vaccinated or cannot be vaccinated because of their own beliefs. And in public health terms, we call them social freeloaders. So they have basically chosen, or for whatever reason, to not contribute to this population dynamic and herd immunity, but hope to be able to depend on the goodwill of the rest of the population. And what we need to worry about is too many people taking that approach, where they depend on the goodwill of everybody else without being able to contribute. And you can think about this in many aspects of public health. Public health depends on people's behavior. If you think about when you come to an intersection, there's rarely a police officer there keeping watch. People choose to do what the right thing is to do, which is to stop at the stop sign or to stop at the red light. But if you were the one person who is the social freeloader who chose to say, I'm not going to pay attention to that rule, that doesn't apply to me, the odds are that you'll be okay because everybody else is doing the right thing and stopping. But the bad part is that you may contribute to somebody else's unfortunate demise. And that's why we really worry about these social freeloaders. So what are we trying to achieve? Well, what we try to do is initially get to the point where we have 80% immunization coverage. That's sort of the baseline. When you look at national goals as they're published or WHO goals, they usually start out with a new vaccine to achieve 80% immunization coverage. Now, it seems like a nice, convenient round number, but it actually does have science behind it. So when you think about 80% coverage, that means 1 in 5 people are unprotected. And that's about the threshold when you can at least start to talk about getting rid of outbreaks of disease. The fascinating thing to me is that what we then try to push towards is 90% immunization coverage. And so that's why most of the goals you see articulated is to try to get to 90% immunization coverage. And while that seems like a very small jump from 80% to 90%, it's actually massive when it comes to statistics. Because we go from 1 in 5 people are susceptible to disease to 1 in 10. And that jump from 1 in 5 to 1 in 10, that's a remarkable statistical anomaly almost. That step is where you actually talk about eliminating disease. And so where we fight the battles to try to get more coverage and more access and more resources for vaccines is to try to get what's relatively easily achievable to what's very difficult to achieve, and to get from 80 to 90%. So the lessons we've learned from immunization programs is that there's a lot of burden of disease. There's substantial progress. There are existing programs everywhere, but there are challenges in each of those programs to not only try to improve, but also to maintain. And that's the hardest part about immunizations. It's not the getting there. You know, when you have polio in the community or you have measles in the community, people usually are eager to get the vaccine. It's when the diseases start to go away and people forget about how bad they are that the battle really has to be fought. Because maintaining people's excitement and interest, and this is not only just the parents and the patients, but this is healthcare leaders and government organizations and the people that fund these programs, getting them to continue to fund things once a disease seems to be going away is sometimes the hardest part of actually maintaining quality of these programs. So I'm going to talk to you a little bit about what we piloted starting way back in almost 15 years ago, and then have been able to gradually expand into other areas in sub-Saharan Africa. And then I'll talk a little bit, if time permits, about how we're trying to address this vaccine hesitancy issue. So when we look at global mortality in children under 5, we've made fairly slow but steady progress over the last 30, 40 years, with the goal in 2015 this year of having hopefully halved the number of children dying from a variety of conditions. Now, the problem being that although this may look like it's going in the right direction, this is still 4 million children dying unnecessarily. I mean, this is still the battle that those in pediatrics continue to fight. And when we look at the progress towards the Millennium Development Goals, you can see that in trying to improve child mortality in children less than 5 years of age, that there's really 2 major areas of the world where we continue to struggle. Sub-Saharan Africa, and then in the Indian subcontinent, throughout these areas. And when you overlay that then with the areas that we've had the most difficulty in improving immunization programs, you can see how closely these are tied together. So this is just taking one routine childhood immunization, which is measles, and you can see that in the same areas, so here's those numbers that I talk about. This blue is more than 90% of children have had these vaccines. This light blue is 80 to 90%. This pink is less than 80%, and the red is the real danger areas. And so you can see that when you look at these areas where we have most of our mortality challenges, it's the same areas that we struggle to have immunization programs be very successful. Now, these numbers are getting better. You can see that many countries in sub-Saharan Africa where we've been working quite actively are at least in the 80 to 90% range. And so that is one of the successes, but we still obviously have a lot of work to do. The burden of vaccine-preventable disease is substantial. In 2008, we represented probably about a third of the deaths that were preventable probably were caused by vaccine-preventable diseases. About 17% of this global mortality in 2007 was related to these diseases. Many of these, unfortunately, are vaccines that we still are not using routinely in many of these areas. So, you know, we're primarily fighting the fight still around tetanus and measles and pertussis, and then Haemophilus influenza B, or Hib disease, is sort of the latest addition to that. But rotavirus and pneumococcus now are really the next ones that need to be moved forward rather quickly. and this is still part of the struggle in getting donors to be able to fund these, is showing that we can actually maintain immunization rates for the other primary vaccines before they will move quickly into introducing some of these newer vaccines. The global immunization vision and strategy, which I'll be in Washington, D.C. in September, where we're going to be rewriting a lot of these programs, was that by 2015, immunization would be highly valued everywhere, and every child, adolescent, and adult would have equal access to life-saving vaccines. Sadly, we did not achieve this goal as much as we would have liked, but we've certainly made progress since when we wrote these back in 2005. Now, the WHO expanded program on immunization is really kind of the centralized, sort of the Center for Disease Control for the world, which has tried to set standards and actually make program materials available for countries to improve their own programs. As I mentioned before, the baseline goals that the EPI program set is to try to get more than 80% immunization coverage, primarily still for this core group of diseases that still do kill children, eventually shifting the goals to a 90% rate, trying to achieve 100% safety with injections. And this came out from a lot of our vaccine hesitancy work, that when you look into communities where people start to refuse vaccines, one of the major reasons is that they don't necessarily trust that the vaccines or the vaccine administration is as safe as it should be. And so they have concerns that the vaccine may actually cause more harm than the diseases themselves. We have a major initiative to try to prevent environmental contamination, with discarded needles and syringes being left in places where they can be accessed and cause injuries, and then to try to add new vaccines as soon as possible, but also to try to build credibility by then recruiting more resources from the government and non-governmental organizations. One version of this, when we realized that by just setting out these guidelines, things weren't going to get better on their own. And even when they provided funding for countries, it's still very difficult for many countries with a lot of different health programs to be able to dedicate and prioritize immunization programs above all these other healthcare programs, because obviously everybody has their pet program. So what actually happened, I think, was really one of the great successes of collaborative efforts from governmental and non-governmental organizations. And it was the creation of Gavi, the Global Alliance for Vaccine Initiatives. And although many of us sort of feel like this has been around forever, it actually only started in 2000. And this was largely pioneered by the Gates Foundation initially to try to bring together these governmental organizations, WHO and UNICEF and the World Bank, along with the vaccine manufacturers and then many other philanthropic organizations, to try to bring together a group to look at what we could do to actually improve immunization programs worldwide. And what they really were able to get a lot of leverage off of was that, unfortunately, even though WHO had put together this organized program through EPI, it actually looked like immunization rates were actually going down worldwide rather than up. And I think that, again, this was in a time period when there were a lot of other demands on the healthcare system, especially the HIV epidemic, that really had distracted from a lot of these other very important programs. So the idea was that countries would apply to be considered a Gavi-eligible country, and it included not only what the economy of the country was, so obviously poorer countries took priority, it also actually required the country to have a commitment to immunization programs. And so what they actually required, which I thought was very controversial at the time, but it's turned out to be really very important, is that the countries needed to dedicate some financing to the programs to show that they actually really were dedicated to trying to improve their immunization programs. And that although the Gavi program would provide the vaccines, that the countries were each required to actually provide the public health infrastructure to make things really work. And so this was really, in many ways, as I said, controversial, but really a new way of looking at aid and a new way of looking at aid programs, because this established a true cooperative partnership where Gavi and the donor agencies were equals with the country and with the health leadership within the countries. And this was a very novel way of looking at things. The traditional aid program, obviously, is a group comes in with a lot of money and says, we know how to do things best and we're going to tell you how to do them, and we may even bring the people in to do them to you, and then hope that when we leave, you're going to keep doing them after we've told you how to do them. Never in a million years does that make any sense if you really think about it. That does not give ownership of the problems to the people that own the problems. That does not give responsibility. It does not give respect. And so Gavi was really, even though, again, very controversial because it required some poor countries to put up some financing that also could have been used for other things, it really then made those countries and their governments dedicated to actually then being participants in this program. And so this has been really a major success. Now, one of the things that we did realize is that some of the countries that needed the help the most just couldn't come up with the resources to actually really co-finance. And so what Gavi actually did a few years later was actually also develop. So there's, if you go to the Gavi website, you can click on each of the vaccines then that have been introduced, and you can see which countries have qualified and what the plan is to introduce those vaccines into those countries. But one of the things they actually realized was that they needed to also contribute to health system strengthening. That by just being an immunization program, you couldn't just drop that into a place that didn't really have a robust healthcare system. And so they identified 55 countries that qualified for health system strengthening funding, essentially to help, not give them money, but to basically help train people within those countries and help build up a human health infrastructure to really be places that you could improve things and build on the back of those immunization programs. Now, as WHO and EPI have moved forward with this Gavi funding, they've run into a whole bunch of challenges, as you do with any healthcare program. Certainly, we run into civil unrest issues that nobody can predict sometimes. There's always a resource issue in trying to find personnel or transport or materials to run these programs. There's sometimes lack of support or lack of investment from either local or central government. But one of the two that we've tried to address with the programs that I've helped work on are dealing with misinformation that leads to vaccine hesitancy, and then deal with a lot of the program administration and management issues. So I'm going to tell you a little bit about the program that we helped cooperate on for almost 9 years in Kenya, which we eventually then have turned over to the Kenyans, and they run on their own now and actually have become a training site for many other countries in sub-Saharan Africa. So this is just to give you it's a little bit hard to see that, but this is 1994, this is 1999, here's 2000. So this is the year that Gavi was created. And you can see that in Kenya, as in many other countries, this is our 80% target goal for where we wanted immunization rates. This is where immunization rates were in Kenya. And this is actually a period of time in the history of Kenya where things were actually relatively stable. This was a time when the government had actually started to really kind of get themselves together, and although it's a relatively corrupt country, it was a period of relative peace. There were a lot of expansions in the economy in that period, but this was during the HIV epidemic, the real sort of heavy period of the HIV epidemic. And so most of the resources in the country were being diverted to try to manage those programs. And unfortunately what was happening is then immunization rates in children were plummeting, absolutely plummeting. So this is BCG vaccine, this is 3 DPT vaccines, here's the polio vaccine rates. In most areas of the country, vaccine rates had dropped to basically 20 to 30%. Gavi came in and by providing vaccine was able to get things turned around relatively quickly in 2000 and then 2001. But what concerned everybody was that there was already this evidence of what may have been some complacency, that there was sort of this happy year of look how good we're doing, and then all of a sudden this sort of drop off. The easiest vaccines to get in are the ones that are given right at birth. So BCG vaccine is given right at delivery, and so that one was fairly easy. Measles vaccine, obviously somebody has to come back at 9 months of age, requires a lot of follow-up. And so there was concern that in this area here that things were going to either go back to this, because the HIV epidemic hadn't gone away, or just level off. And so we essentially proposed a novel intervention, which was WHO has developed all these training and teaching materials, but there was never a budget to bring those in and actually use them to train healthcare workers. And so we had this idea that these were really great tools, but that there might need to be a way of training and improving the management of the program that might actually help improve things. And so we were able to get funding. We got a program started in Kenya, and simultaneously we had a parallel program in Mali that was doing this kind of thing. We chose to start small, and so we chose to start in the western 3 provinces in Rift Valley Province, Nyanza, and Western provinces, where much of the population lives. This is the tea-growing area of the country. It's very fertile, sort of mountainous areas. We centered actually in Eldoret, which is one of the smaller large cities, but specifically decided to stay away from Nairobi. We wanted to stay away from where the large government was, where they would want to manage and take over the program quickly, where they would want to get their hands into the bucket of money rather quickly. And so we chose to work through a university system in a smaller city and pilot this in these 3 provinces initially, with the goal of then expanding to the entire country and then hopefully developing this as a model that can be used in other countries. So these are our 3 provinces. And we decided to do something that made some people unhappy, which was to actually take our time starting and to really go and interview and meet with all the health workers that actually were responsible for the system and find out from them what they thought was wrong with the program and what they thought needed to be improved. We decided that we would get away from both the colonial model and even the WHO model of we know what's wrong because we've seen this in other countries, and therefore that's what's wrong in your country. And said, you know what, this is a problem in Kenya. Let's go to Kenyans and actually run this program through the Kenyans. And so those of us that had helped obtain the funding from the United States were really in the background. This was a completely Kenyan-run program. They did all the teaching and training. We were basically there as advisors. So what we did is go to each and every district hospital and every district clinic in the entire area over the course of a year and interviewed all the managers in these areas, many of which were district public health nurses or district records officers, and looked at what their data looked like, how much they were having problems with people refusing vaccines, and really what the program problems were that they thought were important. It was a fascinating process, if nothing else. People were so appreciative that we would actually come and speak to them, when in fact I was alarmed that they were the experts in their region and their district and in the program, that they're the only ones I thought that would actually know what was going on. We had some interesting things at that time when you went into Turkana region up in the northern part of the country. By governmental rule, you had to have armed guards with you. And so I was one of the first people that ever submitted a receipt for reimbursement for clips of ammunition, which is what you would buy the armed guards as a gift for being with you. So the university had some problem with trying to figure out how to reimburse me for heavy weapons, artillery, but they eventually figured it out. So what we figured out from meeting with all these people and published early in the program was the things that they dealt with was frequent stockouts. They would run out of vaccine, which always got blamed on the central government, but it turned out really it was actually a local district because they needed to be actually forecasting and ordering properly. They had high dropout rates. There were a lot of people that just never made it back, and they hadn't really done much in the way of outreach to try to go out into the communities and help people get access. They actually complained that they didn't get very much supervision, that they felt like they were sort of put out into these sites and they just had to kind of figure it out on their own. And they actually craved more supervision, more people coming and checking on them, and more people essentially showing that they cared about what they were doing. They had a lot of problems with cold chain and the inability to repair those things, and they had always been taught that the government engineers would come through and then repair things, but that didn't happen very often. So we figured out how to train people on how to fix a propane and a solar refrigerator. So I can now take one of those apart and put it back together in the dark with my eyes closed. They lacked vehicles, and that's something that we really couldn't fix. But one of the biggest things that they really wanted that we thought we could help with was actually understanding even what the diseases are that they're trying to prevent and how to recognize those diseases. Because only by understanding when there's actual outbreaks and disease in the community can you then turn around and use that information as a way of motivating both health workers and people in the community that these diseases are real and they actually exist. But the biggest thing that they identified is that most of them had actually never been trained at all in either vaccine program management or even understanding the diseases. That there had been a training about 10 years before for the managers, but all those managers had been transferred in the meantime. And so most of these people were basically doing a great job with what they had, but they just hadn't had all the tools. And so people kept sending them equipment and money and vaccines, but not actually helping them understand really how do you manage a program. So we put together what we called mid-level manager trainings, and the idea was to train trainers who would then be present in every district to keep training as these constant transfers of personnel kept happening. And obviously had to get a lot of buy-in from upper level people, because each of these people needed to be freed up from their positions for 7 to 10 days to come to Eldoret for training. But the goal would be then that each of these people then became a trainer that could then train more people. And I'll tell you, the long story ends with they became a recognized training site for that entire region of East Africa. And so now people from Uganda, Tanzania, and other countries in the region are now sent to this training center that we established that is at Eldoret at Moy University, that provides these kind of trainings for mid-level managers. But the managerial skills were basically sort of this long list here of figuring out how to run logistics, how to monitor, supervise, and evaluate employees, how to do real disease surveillance, a lot of work on communication and social mobilization, trying to work with how do you communicate in communities, especially when rumors start that there is something wrong with the vaccines. And then trying to put together long and short-term plans for improvement and how to organize actual immunization campaigns. And then we put in a number of modules on actually understanding the vaccines themselves and the diseases. So this is sort of how the trainings went. We tried to sample from across all the different positions that were involved in immunization programs in each of these places. So they had ministry people, they had public health nurses, they had Kenyan records nurses, they had district surveillance officers, sort of a whole long list of the people that at least had some activity within the immunization program. And over the course of about 6-7 years, we held 11 trainings and ended up training about 411 people. And then we've been sort of continually surveying the staff in these areas to ask how things have changed then since you've been in a training program. And we've been pleased to see that supplies have been maintained really quite nicely, that stockouts are actually a rarity, that they've got really solid data, and we were lucky that there was also another program to implement some electronic record keeping so that we were able to help provide some of the training for managing those programs. The cold chain maintenance has improved dramatically. Supervision of employees has become the norm and the expectation. Better planning for programs, better disease surveillance, and better communications with the mothers in the community to help them understand both the importance of vaccines as well as helping suppress rumors that sometimes get started. Interestingly, and one of the pleasant surprises was that we didn't really set a benchmark for what we hoped to achieve as far as how many people got trained. But we were thrilled when we recently obtained some data from the government that actually suggested that even after they redistricted the entire country, when they went through their new constitution after the 2007 election upheaval and then and all the problems that were related to that election, was that they ended up with a new constitution and ended up redistricting the entire country, that each of the new districts still has 3 mid-level managers who have been trained at some point, which was thrilling because, again, the transfer problems really kind of diminished these things. And that each district has actually trained then 32 operations level people in their own district. So when you look at the entire population of the healthcare staff across Kenya, we calculated last year that about 1/3 of them at some point have had one of our immunization training programs. And so what we've been thrilled to see then is really vast improvements. The program was done in 2 waves, I forgot to mention. We initially, for the first 4 years, worked in just those 3 western provinces, and then in the subsequent years we were, because of the success of the program, we're able to then have additional funding. We were actually then able to train throughout the entire country, as well as starting a program in the Gambia and in Uganda as well. And so those programs are a little bit younger but still moving forward. So what we saw in the first wave, and remember there was a lot of other things happening, is that we had a pretty dramatic drop in the number of dropouts. And then, so I'll sort of jump forward here to sort of, this is kind of how things went over the course of the coming years. And again, it's this critical kind of trying to maintain something above the 80% line is what we were trying to achieve. So we certainly don't claim that we cured everything and saved the world, but we were at least able to maintain some steady upswing. Now, everybody, of course, has to look over here, and I think this was really a very telling period because, as I mentioned, in December 2007, there was major upheaval in Kenya after the elections when Raila and the government in power had a dispute over what the outcomes of the elections were. And it's fairly dramatic to see what civil unrest can do in a very short period of time to something as successful as an immunization program. So within 6 months, basically no immunization programs or activities happened for about 6 months. And very quickly then immunization rates started to drop. So it's, I think, one of those things that's very sobering to see what can happen when unexpected reality strikes. Immunization rates then overall, then as we've rolled into the rest of the country, we've seen the dropout rates across the country have dropped between 40 and 60%, so that we've been at least able to do a better job of maintaining measles immunization programs. And as we surveyed people, I think it's been interesting to see what the district health workers have prioritized. So they've really prioritized routine immunization activities. They've made a decision, which I think is a good one, which is that they would like vaccination to be such a normal thing that they would like to get away from this idea of campaigns. The campaigns seem like they're something special, that they're disruptive. Sometimes it's even perceived as central government forcing things into the rural areas. And so one of the major things that the workers that we worked with decided on their own is that the best way to maintain immunization credibility was actually to just make it a completely normal activity that could happen all the time. And so they went away from having 1 day a week immunization clinic to doing them every day. They started doing outreach into the markets. So when you would have a village market day, they would actually send immunization workers out to the markets to try to reach some of the families that were very rural. They also developed an adverse events following immunization response team, which really was, in fact, very important because as this dreaded internet thing started to then spread even into these areas of the world, people started to be able to more rapidly get misinformation than they had before when it depended on word of mouth. And so they were wise enough to anticipate that, which we didn't do a very good job of in the United States, that they could actually anticipate these things and then start educational campaigns to counteract those issues really very quickly. They also put together a much better disease recognition program so that they could actually focus efforts when a measles outbreak or a polio outbreak would occur. Now this ended up having some unexpected consequences that we didn't see coming, but because we actually had trained people to recognize the diseases, it actually looked like that as the immunization rates were going up, the rates of the diseases were going up too. And the government was actually rather alarmed that we were somehow spreading disease, but what we were doing was spreading information so that people were recognizing these things. And so families that were out in the rural communities would actually bring their children for attention because they knew about these diseases and bring in all their other children so that they could make sure they were immunized. And the health workers were much better at recognizing these diseases. So fortunately, they had already come up with a communication plan so that as we identified more disease, they used that as a way of actually publicizing immunizations and used it as a positive as things moved forward. They did have to back off on their idea of making things just routine all the time because when they did recognize some of these outbreaks, there was a polio outbreak and a measles outbreak, they had to then mount some campaigns to try to aggressively go into those areas. But that actually went well because they knew that they needed to engage with the leadership in the villages and towns in village gatherings that are called barazas. And getting endorsement from religious leaders and government leaders in these communities really allowed these campaigns to go very smoothly. Now, like I said, there were some unexpected things. This is polio around the world. So this is polio in 1988, was still endemic in most of the world. We're down to 3 countries now. This is 2012. It's still basically the same: Pakistan, Afghanistan, and Nigeria. And so polio campaigns have been successful and routine immunizations have been successful. But you have to recognize that that's where the disease is endemic. These diseases still spread, and they spread rather easily. And so this is one example. This is an outbreak that actually our teams that we had trained in northern Kenya actually first recognized, and then actually were able to track backwards and figure out the flow of the disease. So this was an outbreak that happened in 2009. And essentially what happened is travelers coming from Nigeria were introducing polio into various areas of the countries in the surrounding areas. And like I said, the Kenya outbreak was actually one of the first ones recognized, and then as public health authorities became aware, then they started to investigate backwards. Planes, unfortunately, are now one of these things that allow routine travel of these diseases as well as people and goods, and so they do contribute. And so what we have to make sure people are aware of is that even though everybody's been so happy that we've been able to declare that India is polio-free and many other countries in the Indian subcontinent, that's just that they have stopped circulating within the country. In fact, that these diseases are still out there and can be readily reintroduced as immunization rates drop. And so this is where there was actually wild-type polio still in 2012. So again, even though people can claim that things looked great in 2012 with only 3 countries, there are still plenty of cases of wild-type polio that occur in these areas. And so we need to continue to maintain, even after people have been declaring victory, that the victory isn't over until we can actually stop immunizing, and we're nowhere near to being able to stop immunizing. And so the final part I just want to touch on is something that I spend a lot of time then working on domestically. Internationally, we work really hard on trying to help improve immunization program and immunization delivery. In the United States, most of our efforts are actually designed around trying to make sure that people don't get too complacent and think that we have been very successful. What we find in much of the Western Hemisphere is that our high immunization rates have actually led then to low disease occurrence, and that low disease incidence really does lead to some complacency, not only in the patients and the families, but also in the medical establishment. That there's all these other new exciting things that come along, and it's very hard to get people to continue to dedicate effort and resources into maintaining these programs. And so we have outbreaks now routinely in the United States from diseases that we should have thought were eradicated. I hadn't updated these slides when I sent them over to the team, but we're just finishing a measles outbreak here in the United States that started at Disneyland in California, centered on a lot of families that had chosen not to immunize and a couple international visitors that brought measles into the park, and ended up with 9 states then with measles outbreaks. And we continue to see this over and over and over again across the United States, is outbreaks of disease because we have larger and larger portions of the community that are choosing not to vaccinate their child because they think the vaccine is more dangerous than the disease. And this is really how this looks. So, before there's a vaccine and there's a whole bunch of disease, people are afraid. And as somebody invents a vaccine, and as we improve our immunization coverage rates, duty calls. As we improve our immunization coverage rates, the disease starts to go away. The problem is that as we get to the point where the disease is rare, we get these either real or perceived adverse events that happen after immunization. And the problem is that leads to then this loss of confidence, again, in both the public and in the medical community, that leads into these dips in immunization coverage and these outbreaks. And so this is what we've been living with now routinely over the last 15 years, and which we anticipate, unfortunately, is probably going to start to happen more and more into some of these areas, which is part of a bigger problem, because to try to get then investment into bringing in many of these newer vaccines that we're excited really belong and deserve to be in these areas, you have to be able to show that you can maintain your previous immunization rates to get the donors to actually be willing to do that. And so this is the battle we fight. In Wisconsin, when we ask families why don't they immunize their children, there's basically 2 major reasons. And I've already talked about these. One is that they think the vaccine may harm their kid. So that's this one. There's this strange idea that came out from the United Kingdom about 20 years ago that vaccines might cause autism. There's a preservative that people thought might cause nerve damage. So that's one reason, is that people are afraid that the vaccines may harm the kid. And then the other is that they're not afraid of the disease, that the natural disease is actually better than the vaccine, or that their kid isn't at risk for the disease, or that the disease isn't dangerous. And so it's this combination of I fear the vaccine and I don't fear the disease that you have to be very careful and watch for. And so this is our next phase that we're starting to prepare for in many of our less resourced collaborating countries, is to try to anticipate this happening. This has actually been studied by Heidi Larson's group and a number of others in less resourced areas. And what they've identified is that there are something prompts people to become suddenly afraid. And you can think about this as in almost any program you're doing, that things are going well and then something happens, whether it's political or religious or cultural, something happens. Often with immunizations, it's an adverse event that happens or that's perceived to have happened, and then a rumor starts to spread in the community. And then there's something that sustains that concern, whether it's that there's perceptions that there's conflicts in policy from the government and that vaccines may not be as important as people thought they were, or whether there's a problem in the public health design, whether it's a centralized program that seems to be things being pushed on people versus a decentralized program where it seems like the central government may not be engaged. There's the media and the internet. All these things contribute to these rumors then becoming a sustained problem. And unfortunately, we see then these drops in immunization coverage, which then, we've tried to characterize what are the appropriate responses, and that's what we've been working on. And really the core response is identifying every stakeholder that might have something to do with this problem, but also with the solution. And so what we've realized here in the United States is we need endorsement from celebrities and government leaders and religious leaders, anybody that may provide some credibility to people that may be questioning these things. Because unfortunately, it does seem that people actually respond to people that they shouldn't respond to. And why a movie star or a football player's opinion about vaccines would affect my behavior baffles my mind. And yet we have celebrities that speak out routinely against vaccines, that they claim that they're harming children, and people listen to that. Yeah?
Is there any credible evidence to suggest that there's any validity to parents' concern?
In fact, there is validity only in that the side effects of vaccines are exactly what we tell people that they are. So that vaccines, when they're studied for licensure, have trials that are on the order of 100 to 200 times larger than any other drug trials. Drug trials, you have a medical condition, you have a drug, and you can see the medical condition get better or not, and you know what the side effects are. Most drugs that go to the FDA are tested on about 5,000 to 10,000 people. Vaccines are given to people hoping nothing happens, so that ultimately nothing happens, right? And so those trials to prove the null are usually on the order of about 200,000 individuals in each arm of the trials. So we're much more careful about vaccines, both in the United States and worldwide, in identifying safety things because they have to be held to a different standard. And so what we find over and over again is exactly what we've been saying all along. They all have the exact same side effect profile that people are told about: fever, pain, swelling. And if it has anything more severe than that, they don't get approved because you're not treating a condition, you're preventing a nothing. And so vaccines are held to a completely different standard. It's a good question. And so that's part of why it's easy to fight this fight when you're in my shoes, because we have science on our side. The problem is we've depended on science being enough, and we realize we actually have to play the game of communication and dealing with all these other components of how people behave, because they don't always behave rationally. As we always say about public health, the worst thing about public health is the public. You can't, if we could just tell them what we know is right and what's best for them and have that be the end of the story, it would be easy. But they have behavior, and they do things that we don't want them to do, and they have opinions that aren't always colored by the right information. And so what we spend a lot of time doing is figuring out how do you actually provide better information to them. So when we look at what are the ways we try to restore public confidence in vaccines, it's trying to identify everybody that can actually be stakeholders in the solution, trying to be very transparent about decision making. I think that's been one of the things that probably bothered people the most over time, was that there seemed to be the sort of outsiders from somewhere else who seemed to know everything about everything telling people how to do things. And I think that the EPI program that WHO designed was really very wise in giving the control of the programs to countries. And then the Gavi program sort of built on that same idea of having partnerships rather than dictating how things are done. But as you appropriately asked, I think one of the things we do need to make sure that we do is be honest and disclose when there are uncertainty and exactly what the risks are. Because these are biological products going into biological organisms. Things happen, side effects happen, and so we need to be prepared to monitor for those and respond to those. And I do think the one thing that is important to sort of reflect on your question was that I think we were a little too rosy about vaccines for too long. I think that we sort of portrayed them as the greatest thing ever, nothing to worry about, trust us. I'm from the government, I'm here to help. And those are famous last words. And I think that we needed to be a little bit more honest that there are side effects to these things, but that they're side effects that we are willing and in fact think are very reasonable to tolerate. So in the United States, about 20 years ago, we created mandatory what are called vaccine information forms, that for every vaccine, a family has to be given by law a form that is actually put together by experts and by parent advocacy groups that's supposed to provide fair balance. It tells you all the good things about the vaccine, all the bad things about the disease, and all the potential side effects that have been identified. I don't know how to turn that thing off. From the vaccine. And those by law, because we do feel like providers weren't being completely upfront with people and saying, like, look, this vaccine's really important, but there's a pretty good chance your child's going to end up with a swollen arm and maybe will have a little bit of fever. You know, as long as you tell people and are honest with them, then they say, oh, my child's got a swollen arm and a fever. Okay, but if you didn't tell them that, all of a sudden it's this, oh my God, my child's got a swollen arm and a fever. And they said this vaccine was the greatest thing ever. Suddenly the credibility, it's that simple, and yet it's that complicated to make sure that that's the message. So the other part is just making sure that what we've also found in looking at this more deeply is that vaccine safety, while we've focused on that as a major reason around vaccine hesitancy, we've also been working on sort of how do you communicate these things better. And this is where we've started to sort of walk gently into this whole social media, internet communication, marketing. And this is actually an older paper, but this has sort of been, I think, leading a lot of initiatives that people have been working on about trying to figure out how do you communicate properly by engaging in the community, doing a needs assessment to understand what does the population really want and what do they need, rather than designing things as one size fits for everybody and trying to figure out what's right for that community. And so the bottom line on all of this for these information campaigns and dealing with diseases and rumors is the key is really partnerships and developing coalitions of people that are traditionally involved in health and public health, but also people that may not be traditionally involved. And so dealing with schools and religious organizations and government organizations, anybody that may have the ability to endorse the importance of what these programs are about. Hiroshi Nakajima was the Director General of the WHO some years ago, and he said that we must recognize that most of the world's health problems and premature deaths are preventable through changes in human behavior and at low cost. And I think immunizations are a great example of that, that you know, the cost of vaccines is actually tolerable. It's and in fact, that by Gavi sort of providing a way of underwriting the costs of these programs was very important. But really the more important part was actually the behavior and training of managers and how they interact with the communities to continue to maintain this credibility of the programs. And so we've gone back to this over and over again when we look for both funding and for support for programs about why training and education is so important, because it's the human behavior that we're trying to change more than anything. So the messages that we've identified and that basically end up being kind of the final part of this is that vaccination, when we're communicating with families and communities, vaccination is one of the most important ways parents can keep their kids safe. Vaccines are, in fact, very safe and very closely scrutinized. The diseases are much, much greater of a risk than the risk of vaccination. And the parents that choose to withhold vaccination are basically making a decision to leave their child subject to the dangers of a disease, that they're making an active decision to leave their child vulnerable when they could be protected. And when you put it in those kinds of terms, people seem to change their behavior. When you say you are making a decision, by not putting your child in a car seat, by not wearing a seatbelt when you're driving, you're making an active decision for yourself. But when you're choosing not to vaccinate your child, you're choosing to leave your child vulnerable to something that you could have prevented. And parents will think very differently when you put it in those kinds of terms. So what we've been trying to do with all these programs, again, the Kenya was just one example, is trying to get basic financial resources, trying to achieve a sustained political commitment to maintain these programs, trying to pursue collective action and doing these things both domestically and internationally, and then trying to find more and more health advocates that will speak on behalf of immunizations. And I'll just finish up with a couple of things that we've helped develop. One is a program called shotbyshot.org, which is a website which actually has specific stories for every disease from families that have actually suffered through these. There's been a lot of people in the media in this country who claim that their children were injured by vaccines, and we decided that we would finally respond by creating the information that people would really need to have about the death of unnecessary death of children or unnecessary suffering of children that could have been prevented. There's a number of campaigns now around the United States, which are starting to move into other countries, about trying to develop programs to use every member of the healthcare community, but also other members of the community, and trying to identify advocates that will actually speak out on behalf of vaccines. We have a centralized program in the United States called the Immunization Action Coalition, which is a non-governmental, non-pharmaceutical company clearinghouse and storage site for essentially every teaching material we've ever developed. And it's a little cumbersome to navigate, but we've established this so that providers around the United States and the world can use these. We have these vaccine information sheets for places that want to use these now in 56 languages. Just added Tagalog from the Philippines this year. So really a very robust site. And then the materials that we help pilot from WHO, these mid-level management modules, are now publicly available. The WHO used to provide them to their country leaders, but actually realized that they just needed to make these available for anybody and anybody that wants to do immunization training. And so these are now available on their site. And then the US AID program also has put together kind of a practical field guide for immunization programs that we share. I have a lot of collaborators to thank that I won't go through all of them, but I've learned a lot from a lot of different people. We've shared a lot of information with a lot of people, and I think that this is an ongoing effort. And then finally, I think when I was thinking about quality improvement, when I met many of you yesterday at Lori's house, I was sort of sitting in my office early this morning, and I have this, amongst many other things, tacked to my wall. And when I think about quality improvement, I think that what you're actually trying to do is change how people act and change how people behave. And I can't think of a better quote than "be the change you wish to see in the world." And that's why I'm so grateful that all of you are here and are willing to be able to be part of this conversation about how do we improve the quality of the programs that we all work within. So with that, I'll finish up. And